Hi guys, my name is Asad and today I'll be talking about cardiac dysrhythmias. So before going into this, you must know what is arrhythmia. It is basically a normal rhythm of the heart that you can observe on your ECG strip. Now what is arrhythmia? It is simply absence of a rhythm, and dysrhythmia is abnormal rhythm. They arise due to either fault in formation or either conduction of impulses. So this is the normal rhythm of the heart that consists of PQRST, and it is observed on an ECG strip. It is consist of your P wave, QRST complex and your T wave. Now the P wave represents arterial depolarization, the Q wave represents the normal left to right depolarization of the interventricular septum. R wave represents the electrical stimulus as it passes through the main portion of the ventricular walls. Now the S wave represents depolarization in the Purkinje fibers, and now finally the T wave represents the depolarization of the ventricles. Now the first dysarrhythmia I will discuss is premature arterial beat. It is basically an extra heartbeat caused by electrical activation of the atria from an ectopic site before normal heartbeat would occur. Now I will show you how you can identify it on ECG strip. Now look at the P wave and compare it to normal. It is way upright that what is in the normal, and you can see that it is very close to the T wave. This actually represents the premature arterial contraction. So moving forward, we're going to talk about premature ventricular beat. So premature ventricular beat, or you can call it contractions or PVCs, these are the early depolarization of the myocardium that actually originate in the ventricle. And because so your P wave is absent on your ECG graph. Now we're going to talk about premature junctional beats, and these beats arise due to aberrant impulses that originates in the AV junction and actually occur prematurely before the next expected P wave. Because of this, you will observe an inverted or either absent P wave. Now moving forward to the arterial flutters. In this dysarrhythmia, arteria beat too fast, about 200 to 400 beats per minute, which will ultimately cause multiple P waves to be produced on the ECG strip. And you will observe the sawtooth appearance that I highlighted. Now moving forward to atrial fibrillation. In atrial fibrillation, the beats increases above 400. This will cause the P wave not to be seen in ECG, and hence you can only observe fibrillatory waves on the ECG graph. Other difference from flutter, apart from high beats, is that it occurs irregularly, unlike arterial flutter. Now talking about supraventricular tachycardias. Supraventricular tachycardia means that tachycardias that occur above your ventricles. So there are two, proximal atrial tachycardia and proximal junctional tachycardia. Now proximal means that the episode of the arrhythmia occurs and end abruptly. And now moving forward to the proximal atrial tachycardia, you can see the graph. You can see that in one part of the ECG slide the heartbeat is very fast and the later part has a very slow heartbeat. So it shows that it is proximal, that it begin or end abruptly, and the other part is normal. Now the arterial rate during atrial tachycardia is usually around 100 to 200 beats per minute. So this actually causes a narrow complex of P wave that has a slight different morphology that you can see in normal. You can see the P wave in the proximal atrial tachycardia and the normal part. Now let's talk about proximal junctional tachycardia. So it is associated with the generation of impulse in a focus in the region of the AV node, and it is due to an AV dissociation, and this will form a narrow QRS complex on your ECG graph. So now talking about ventricular tachycardia. So ventricular tachycardia arises from, obviously the name suggests that it arises from the ventricles. It is basically defined as your 3 or more heartbeat in a row and at the rate of around 100 beats per minute. In ECG graph, you will find a wide QRS complex, and this is the characteristic of your ventricular tachycardia. Now talking about first degree AV block, you will find PR interval of more than 0.2 seconds on the ECG graph. It is not a complete block, and only the signals are slowed through the AV node. Now moving forward to the second degree AV block, it has two types. Type 1 Mobitz 1 Venkipak and type 2 Mobitz 2 or Hay. Now in type 1 there is gradual increase of PR interval before QR drop. So there is the time period of PR interval is increasing gradually and then QRS drops. In type 2 that is not the case. In type 2 QRS doesn't drop after the gradual increase of PR interval, but it drops right away without any increase of your PR interval. And the gradual increase of PR interval before the QRS drops is your Venkipak. Now looking in the type 1 and type 2 charts, you can see that in Mobitz 1 or Venkipak, you can see there is a gradual increase of your P and R interval. Now in the Mobitz 2 or Hay, you won't see the same. The interval is same, but the QRS dropped eventually. In the Venkipak, the PR interval increased and then your QRS dropped. Now moving forward to the third degree heart block, that is complete heart block, in which the ventricular rate is independent of the arterial rate, and the arterial rate continues to have 60 beats per minute, and the ventricular rate is independent of the arterial rate and is running on 27 beats per minute. Now none of the arterial impulses are conducted to the ventricles, and you can see the QRS complex is way all over the place, and your P wave you can see gradually coming but having no effect and are not causing any QRS wave to appear. So bundle blocks, talking about the last topic of this video, that is bundle block. Bundle block is a condition in which there is a delay or blockage along the pathway that electrical impulses travel to make our heartbeat. Now it has of two types: right bundle block or left bundle block. In right bundle branch block, you will observe a bunny ear in your anterior precaudal lead, and you will also observe slurred S waves in lead 1 AVL and on V5 and V6. In left bundle branch block, QRS duration will be 120 millisecond like your left bundle branch block, but there will be absence of Q wave in lead 1, V5 and V6, and you have monomorphic R wave in lead 1, V5 and V6. So thank you guys for watching, and if it increased your information and you liked it, so please like this video and subscribe and turn on personalized notification if you want. Thanks for watching.